evidence and clinical decision making for stroke prophylaxis patients in atrial fibrillation. And our today's speaker is Dr. Professor Vivek Gupta sir. Dr. Professor Vivek Gupta sir is a senior interventional cardiologist at Indraprasth Apollo Hospital, New Delhi. Dr. Vivek Gupta sir is an interventional cardiologist of international fame with more than 25 years of experience in his field. He has affiliated in the Apollo Hospital since 1998 and carrying out the clinical as well as invasive work. He was selected for the prestigious fellowship in France and was trained by one of the most eminent cardiologists, Professor Alain Krieger of the world in the skills of angioplasty. He was the youngest in the age to attain the position of senior interventional cardiologist in prestigious Indraprasth Apollo Hospital, New Delhi. He has performed thousands of simple and complex angioplasty stent during his 25 years of experience in India and abroad, which has been crucial in saving huge number of patient lives. Dr. Professor Gupta is a great teacher, and to help the cardiology community, he established international teaching program, Indo-European course of revascularization, which is also in the process of providing training to state government doctors, which will impact improvisation of Indian healthcare. So with this, I request to Dr. Professor Gupta sir to please take us through the session on the topic. Sir, I have passed on the presenter rights to you, sir.
So thank you very much for the nice introduction, and I want to see my full photo on the screen. Are you seeing my full photo? I'm not seeing here.
Yeah, we can see sir, your image is there. Sir, for slide presentation on the left hand side on the top, file, edit, share. Share आप click कर दीजिए sir. Yeah. You can open your slide, sir.
Okay.
Yes.
So good.
Yeah. Your voice is audible, sir. Your image is very clear. I will request the doctor audience to share the query if you have any questions in the chat box or on my mobile number.
Okay, so good morning and good afternoon, I would say. This is Dr. Vivek Gupta, Senior Cardiologist from Apollo Hospital, New Delhi. And the topic for today, as we know, is how to prevent stroke and what are the evidences. Atrial fibrillation is a very common thing, and we have two types of atrial fibrillation. One is, of course, we all know that valvular atrial fibrillation. Another is non-valvular, which is more common in the elderly population. So the topic is relevance of real-world evidence in clinical decision-making for the stroke prophylaxis. Prophylaxis means prevention in the patients of atrial fibrillation. I am Professor Dr. Vivek Gupta from Indraprasth Apollo Hospital, and I am going to talk in the next 15-20 minutes about what are the evidences, what anticoagulants should we use, whether we have a new agents which are better, and what are the real world evidence. So this is disclaimer slide. So atrial fibrillation is irregular and often rapid heart rate that occurs when the two upper chambers of your heart, that means the atria, experience a chaotic electrical signals. The result is a fast and irregular heart rhythm, and this is known as atrial fibrillation, which can be easily diagnosed by ECG. And of course, once you have a patient of atrial fibrillation, there is a big number of tests we do, like echocardiography and Holter monitoring. The heart beats at the rate of 100 to 150, and the patient feels that he has palpitation. Overall, in general, atrial fibrillation does not lead to death. It is safer than ventricular fibrillation, which is almost cardiac arrest. But of course, atrial fibrillation has a long-term implications. So there are two ways we treat. One is control of the rhythm, and that means rhythm change back to sinus rhythm. Another is control of the rate. So there are beta blockers, digoxin and calcium blockers, which are given to control the rate. So there are patients of chronic atrial fibrillation who are there for last so many years in atrial fibrillation, and we cannot change back to the sinus rhythm. And these patients, we require beta blockers or calcium blockers to control the rate from 100 to at least 70 or 60. And many patients of valvular AF, they require digoxin, which is being used for a long time, over years together. The topic today is not that how to control the rate and how to control the rhythm back to sinus rhythm. The topic is because a lot of patients who are in chronic atrial fibrillation, they have a tendency to go into throwing the embolus, thrombus formation inside the atria, which can go into the brain and lead to stroke, paralysis. And this is dangerous because atrial fibrillation can lead to paralysis, hemiplegia, or severe stroke, or hemorrhagic stroke, ischemic stroke, various kinds of stroke, which leads to clinical condition of paraplegia, right or left, sometimes aphasia, that means patient cannot speak. And therefore we have to find some way out to reduce the incidence of stroke in atrial fibrillation. But why stroke happens in atrial fibrillation is because when the atria is beating at the rate of 150 to 200 or 300, there is hardly any flow inside the atrium. Atria is the upper part of the heart, while ventricle is the lower part of the heart. The blood flows from atria to ventricle, and then finally the ventricle pushes out to the whole of the body. This is how the heart functions. The heart is functioning like this, that you have basically a heart which is pumping, which has 4 chambers, upper 2 are atria, I repeat, because a lot of doctors are there, and I would also I'm making it more simple so that the public can also understand. So when atria is beating at the rate of 200 or 300 or 250, well, there is hardly any flow of the blood, and therefore there is a possibility of thrombus formation. This thrombus from the left atria goes into the left ventricle, and it can be passed on to the body. It can lead to either a stroke if the clot goes inside the carotid artery and finally into cerebral arteries. This will lead the blocking inside the brain arteries, and that will lead to a stroke. If this clot goes into the body, like it goes into the GI tract, for example, it can go to the lower limb, it can go to the upper limb, it will cause systemic embolism. So these two common complications are very common. And what is the incidence? The incidence of ischemic stroke in the first year of AF atrial fibrillation diagnosis is 6%. And this can be 9 to 6% at the end of follow-up period. Thus 60% of all stroke occurred in the first year after AF diagnosis. This indicates that it is essential to initiate treatment for atrial fibrillation, prevention of a stroke as early as possible. So this is the background. So what we are going to talk about is what are the medicines available and which medicine is better in the prevention of paralysis in the patient who is having non-valvular atrial fibrillation. This is the topic, and on this background I will go. For years together, warfarin, which is a tablet available all over the world, is being used as an anticoagulant in the patients of atrial fibrillation, and also this is still being used very commonly, and it is almost a must to be used. It's a must to be used in valvular AF. What is valvular AF? So I don't have a slide, but I would like to explain to you. Valvular AF means the patient who has got a mitral valve disease or he has got any other valve disease, and then because of dilatation of the atria, the atrial fibrillation happens. This is known as valvular AF, and warfarin is very much important to be given, and you have to control the blood coagulability and how much blood is thin by the measurement known as INR, which is there is a blood test. The novel oral anticoagulants, which are 3 and 4, rivaroxaban, dabigatran, and apixaban, these are the 3 important innovation, I would say, during the last 5 to 10 years, I would say. And these are actually very important because they do not require the monitoring by INR. This is the most important advantage over warfarin. But do we have other advantages? So we have a lot of data available for non-valvular AF. That means the patients who are ischemic heart disease, elderly, more than 65, 70, they go into atrial fibrillation as a part of, because the atria is little dilated, or there's some chaotic rhythm, or there is some ischemia in the atria which can lead to abnormal rhythm, atrial fibrillation. And these patients are getting more and more common, especially with rising age all over the world. In these cases, you can always give warfarin. But of course, as I told you, that warfarin requires monitoring, number one. And secondly, we're now going to discuss the data whether these novel oral anticoagulants are better than warfarin. And if they are better than warfarin, then whether out of these 3 which is available in India, the 4th one, endoxaban, is not still approved in India. Out of these 3, which one has an edge over others by next few minutes of trials. So objective of this presentation would be the review of NOAC, NOAC is better than warfarin in randomized clinical trial. I'll discuss about 3 trials which will tell us that NOACs are better than warfarin, and this is a randomized clinical trial which are conducted and published in very important journals about 5, 7, 8, 10 years back. Then we will discuss the real world data. That means the patients who are being discussed which are not in the trials, and we have an analysis of estrophen analysis, and we'll see that NOAC is better than warfarin, and that here we have also the possibility of head-on comparison of 3 NOACs which I told you: rivaroxaban versus dabigatran, epivexan versus dabigatran, epivexan versus rivaroxaban. So this is I'm going to discuss in the next few slides in the estrophen analysis, which is actually a real world data. So briefly coming on to the NOAC in randomized clinical trials. So review of the NOAC, which is better than warfarin in randomized clinical trials. These are the RCTs, and there are basically 3 RCTs, which is RELY trial for dabigatran, Rocket AF trial for rivaroxaban, and Aristotle trial for apixaban. So these 3 trials have been very instrumental and which has proven beyond doubt that NOACs are better than warfarin in non-valvular AF in the treatment by these 3 trials. So let us do the meta-analysis by these trials. You can see this is an important slide. You can see RELY trial, which was published in 2009, which is for dabigatran. It was 2 years follow-up. Rocket AF trial, which was in 2011, it was for rivaroxaban versus warfarin, and the Aristotle trial was basically for apixaban versus warfarin. So here we are talking about NOACs versus warfarin. We are not talking about NOACs to NOAC. There is no, in this randomized clinical trial, there is no head-on comparison of the NOAC versus NOAC. So, but this is important because warfarin is established for years together, and this is still being used in the valvular atrial fibrillation. So in non-valvular AF, whether we can do a little better, because what is the aim? Aim is, of course, the prevention of a stroke, and we should not have at the same time major bleeding. When you give anticoagulant, there's always a possibility that patient can bleed either in the brain or he can also have pulmonary hemorrhage, or he can basically, most important is GI bleeding and the hemorrhage which can happen inside the brain. So these 3 trials, randomized clinical trial, RELY trial for dabigatran, Rocket AF for rivaroxaban, and Aristotle for apixaban, has tried to prove beyond doubt that overall NOAC is superior. If you see this RELY trial for dabigatran, 34% risk reduction in the prevention of stroke and systemic embolism. For Aristotle trial apixaban, there is 20% risk reduction in terms of stroke and systemic embolism, and rivaroxaban, the p-value is not significant, it is 12% risk reduction, but here these 2 are significant for Aristotle, for apixaban, and for RELY for dabigatran. So in combined together, all these 3, there is a 19% risk reduction in all the NOACs versus warfarin in the prevention of stroke or systemic embolism. What about the major bleeding? Because whenever you start an anticoagulant, the patient has chances of bleeding, and therefore you have to be safety. That means there are 2 issues. One is efficacy, another is safety. The efficacy is you will find out by the prevention of stroke or systemic embolism, and efficacy and safety is found by prevention of major bleeding. If you see the data from the same trial, RELY trial, Rocket AF, and Aristotle trial, and overall combined, there is a risk reduction of 14% in the combined versus warfarin. So warfarin patients will bleed more as compared to NOAC patients. This is basically the results. This is very significantly see there's 29% risk reduction in the Aristotle trial in apixaban as far as bleeding is concerned versus warfarin. That means the bleeding will happen in apixaban also. But as compared to warfarin, NOACs are safer in causing bleeding in the patients of non-valvular AF, and these are the studies published in NEJM. Going on to the various RCTs, I will a bit of details what about these 3 trials, but before that I would like to also discuss about the CHAT score, which is very important for the risk evaluation for the atrial fibrillation. And CHAT score, and now CHAT's FAST score: C for congestive heart failure, H for hypertension, A for age, D for diabetes, and S for stroke, and CHAT's 2 score. And the scoring is done by this: 1 point is for diabetes, 2 point is stroke, 1 point. For example, a patient who has got a previous history of stroke and diabetes mellitus, the CHAT score will be 3. That means these are high risk for future stroke. if patient also has a prior MI or this peripheral vascular disease or aortic plaque, and the patient is also having elderly more than 65, then overall points will be a patient of diabetes with a prior stroke or thromboembolic event, and with a history of vascular disease and elderly. So if you combine 1, 2, 3, 4, 5, he will be having CHATS 5 score, which is a high risk for future events. So these are how we are basically evaluating the atrial fibrillation patients of the risk of having stroke. So this is just to tell you a little about CHATS score. But coming on to the trials again, so a little bit more about the RELY trial, which was published in New England Journal of Medicine in 2010. And they have actually compared dabigatran versus warfarin, and the two doses which have been tested or tried, 110 milligram twice a day and 150 milligram twice a day. And the primary efficacy point was stroke or systemic embolism, prevention of stroke, and primary safety endpoint was major bleeding. And they found that primary efficacy point basically was 34% risk reduction in patients who were in dabigatran, and this was more significant in those patients who have 150 milligram twice daily. But at the same time, the risk reduction was not significant in dabigatran 150 milligram versus warfarin. But if you take 110 milligram, the bleeding risk was also less in this trial. Coming on to the second trial for rivaroxaban, which is actually NEJM, published in NEJM, and ROCKET-AF trial. Here the CHATS 2 or more than 2 patients were evaluated versus warfarin. I repeat again, these trials are NOAC versus warfarin. ROCKET-AF is for rivaroxaban, and I have just discussed about RELY trial that was for dabigatran. So rivaroxaban 20 milligram OD or 50 milligram OD, if the creatinine clearance was less, was compared with warfarin. And warfarin, the patient INR was tested and it was kept between 2 and 3. Again, the primary safety endpoint was major and non-major clinically relevant bleeding events, and efficacy was, of course, stroke. The median age was 73. And in this trial, there was no significant difference in the superiority or overall bleeding risk. Also was not much less, not less in the rivaroxaban group and versus warfarin group. That means this trial failed to show the superiority of rivaroxaban versus warfarin, and published with these are patients who were CHATS score, and this was also published in NEJM in 2011. Coming to the third trial, which is Aristotle trial for apixaban, and here the patients were basically CHATS score 1 or more than 1. That means, of course, they were mild to moderate risk, and if they were also high risk cases were also included. Apixaban, the dosage which was included was 5 milligram BD, and warfarin was, of course, you have to match the INR. There is no fixed dosage. Lot of patients differentiate. For example, there are patients who will require 2 milligram, 3 milligram, 4 milligram, 5 milligram. You have to keep changing the dose. Here the doses are fixed. This is one more advantage of NOACs versus warfarin. So here the efficacy point was that 21% risk reduction in the primary efficacy point of stroke or systemic embolism, while the major bleeding was also less. So this Aristotle trial actually established apixaban superiority over warfarin, and this was published, and they have a huge number of patients data which were collected. So summary of various NOACs in terms of safety and efficacy, if you see, this is a very important slide which will tell you the warfarin versus NOAC summary of major efficacy and safety outcomes. If you see apixaban is better in terms of stroke, ICH, intracranial hemorrhage, death and major bleed, all 4. These are the important points, because you see, you don't want to have stroke, you don't want to have intracranial hemorrhage, you don't have mortality, you don't want the patient to die, and therefore major bleeding should not be there. These are 4 points which any clinician will be concerned whenever he starts anticoagulant. So if you see this data of summary which were published these are the trials for dabigatran, in terms of stroke reduction and death, there was no significant difference, especially 110 milligram. But when you see 150 milligram dabigatran, this was better than warfarin in terms of reduction in stroke and of course in terms of reduction of ICH. But there was no data as such for the major or bleed or death. Rivaroxaban was only better in terms of ICH. There was no reduction, there is no major reduction in stroke or death. While apixaban, this is important to note for all the audience, that these Aristotle trials showed that in terms of efficacy, prevention of a stroke or systemic embolism, and of course safety in terms of reduction of intracranial hemorrhage, we are talking of versus warfarin. In terms of reduction of intracranial hemorrhage and death or major bleed, this was significantly better as compared to warfarin. So if you see all the four criteria of efficacy and safety, apixaban is scoring better than warfarin in all these four. This is the summary of the trials, which are randomized clinical trials. So coming on to the real world evidence, what do we mean by real world evidence and how it can be used for NOAC or stroke prevention? So real world evidence is actually when you do a data collection and you do retrospective analysis. So real world evidence complements RCT. When you have already RCT, which have some data, so RCT provides evidence on safety and efficacy on the intervention. The RWE, that means real world evidence, is the product of data collected through observation during the current clinical practice. Real world evidence can complement evidence from RCT by assessing wide range of outcomes that are representative of everyday clinical setting. Aristophane study is the main purpose of my talk about this, to discuss about this Aristophane study, which was actually an American study and published in Stroke, which is an important journal in 2018. And this actually was showing the effectiveness and safety of oral anticoagulants among all non-valvular atrial fibrillation patients. Basically, among non-valvular atrial, I was starting my talk, I told you we are not talking about valvular AF, we are talking about non-valvular AF. So among non-valvular AF, we had found that Aristophane study did a very good, important retrospective analysis and published in Stroke. And what they were trying to find they got the inference, and this is the conclusion of the data. And what inference they got? They compared NOAC to warfarin. They had NOAC to NOAC comparison, and high CHADS score and high bleed score were also included in this actually comparison. When they got the inference, they had a retrospective analysis, and then they inferred. They got conclusion from that analysis. So coming on to the Aristophane US study, it was a retrospective observational study from January 2013 till September 2015 and published in New England Journal of Medicine later on. So this is actually published in 18, but the data which was included was from 2013 to 2015, and more than 4 lakhs patients were observed. The design was 4 lakh patients. Out of these 4 lakh patients, 1,08,000 were in the Apibaxan group, dabigatran was 37,000, rivaroxaban was 1,53,000, and warfarin was 1,67,000. So maximum was of course warfarin group, but of course apibaxan was apaxaban was 1,08,000 and rivaroxaban was 1,53,000. Dabigatran was little less. So this is an important study, and which is very going to I would like to discuss about propensity score matching. It is important because when you have an observational study, you have to have a statistical analysis by something known as PSM. It is a statistical approach to construct matched samples of treatment control pairs to minimize the difference between the two groups. It reduces the possible bias associated with the confounding variables in observational study, and this is how they have the population with varying characteristics, and they match it differently, and they make a study group and they do further matching, and then they have a treatment and the control group. So coming on to the baseline characteristics in the patients who were for the NOAC to warfarin and then NOAC to NOAC. The baseline, there were two groups here. Basically, they had compared NOAC to warfarin, and the second important was they had also the possibility of NOAC to NOAC. That means apaxaban versus dabigatran or dabigatran versus rivaroxaban. I will tell you. So the baseline characteristic was, the important point is that most of them had a CHADS score of more than 3.9. They are high risk patients. The mean age was 70 above or 75 above, and of course they had also congestive heart failure, diabetic, renal disease, stroke, peripheral vascular disease, and that made the CHADS score more than 3 or more than 3.5. This is for the patients who were NOAC to warfarin. Similarly, in the group analysis of NOAC to NOAC, they had again the CHADS score which was more than 3.5, around 3.5, and high blood score was also high. And of course they had various type of patients, and mostly patients were more than 70 years age. Coming on to the results of this Aristophane study. The result was constructed from the observational study. So let us do the one by one. So this is a study, apaxaban versus warfarin. So they are not combined arrow. This is something like what Aristotle study was there. Aristotle was a randomized clinical trial where they had apixaban versus warfarin. But this is observational study, and what are the results from this data, apixaban versus warfarin? So the summary was, compared with warfarin, apixaban was associated with lower rate of stroke or systemic embolism, ischemic stroke as well as hemorrhagic stroke, systemic embolism, major bleeding, GI bleeding, intracranial hemorrhage, and other bleeding. So in all the things you see, if you see the ischemic stroke, total stroke, hemorrhagic stroke, all were less as compared to warfarin in this observational analysis. Similarly, if you see the overall bleeding, GI bleeding, ICH, as well as other bleeding, they all were significantly less. And you see if you see the risk reduction was very much. If you see the overall risk reduction, that means which is about 36% risk reduction in the overall stroke, and similarly the major bleeding was 40%. So this is very significant to see that this apixaban versus warfarin in all the areas of safety as well as efficacy as well as safety, it was doing better than warfarin. This is Aristophanes study. Coming on to the dabigatran versus warfarin results. Dabigatran versus warfarin propensity score matched cohorts. Compared with warfarin, dabigatran was associated with lower rates of stroke and systemic embolism, hemorrhagic stroke, major bleeding, ICH, other bleeding. But ischemic stroke not much reduced in the, this should be dabigatran. So in the dabigatran group, ischemic stroke, we see the ischemic stroke, there is no difference between the ischemic stroke reduction in dabigatran group versus warfarin group from the overall stroke was less, about, this is 18% reduction, but ischemic stroke was not much reduced, while hemorrhagic stroke was reduced. So this is the difference between what apixaban showed here. Here the ischemic stroke was also reduced, while in the dabigatran group, the ischemic stroke did not have any major impact versus warfarin. So this is observational analysis. I am repeating again. Aristophanes is an observational analysis, retrospective analysis, and the results are constructed by a very selective PSM approach. So rivaroxaban versus warfarin results. If you see the results here, compared with warfarin, rivaroxaban was associated with lower rates of stroke, GI, ischemic stroke, hemorrhagic stroke, and ICH, but higher risk of bleeding. This is different from what randomized clinical trials showed for rivaroxaban, because there was no major risk reduction or efficacy data in the stroke in the trial, which was the randomized clinical trial. But here, the rivaroxaban shows, of course, reduction of overall stroke, ischemic stroke, but high rates of major bleeding. So this was something, safety data is not so great here, because the overall bleeding, GI bleeding and major bleeding was little higher in compared, although it was reducing the stroke, but risk reduction is about 31%, not 38%, which was there. It is about 21%. So this is the data from rivaroxaban. Coming on to the analysis which has been constructed from this Aristophanes study, NOAC versus NOAC. This is important, because whenever the physician is seeing the patient, he sees these three NOACs are available, oral anticoagulants, apixaban, dabigatran, rivaroxaban. So which one I should choose? So now you have data where you can show something with definite, that apixaban versus dabigatran. And this is again propensity score matched cohorts from Aristophanes study. Compared with dabigatran, apixaban was associated with lower rates of stroke, overall and ischemic strokes. Aprivaxan was better than dabigatran from this cohort data. And if you see, it is 28% risk reduction in overall stroke. Comparison, direct comparison of aprivaxan with dabigatran, and this is 28% risk reduction, while major bleeding was also less, and which is about 22%. So compared with dabigatran, I repeat, apixaban was associated with lower risk of stroke, overall ischemic. Hemorrhagic stroke was similar, but it was not worse, and major bleeding overall is better. ICH is almost equivalent. If you see intracranial hemorrhage, there is no major difference. But overall, apixaban is showing better results in terms of safety as well as efficacy. Coming on to apixaban versus rivaroxaban. This was apixaban versus dabigatran. Now we are talking about apixaban versus rivaroxaban. Compared with rivaroxaban, apixaban was associated with lower rates of stroke, and this is, if you see, 20% risk reduction, better hazard ratio, apixaban versus rivaroxaban, while major bleeding is significant. But here lower rates of major bleeding, but major bleeding was significantly 45% risk reduction in the apixaban group versus rivaroxaban group. This is very important to understand. Coming on to dabigatran versus rivaroxaban. Dabigatran versus rivaroxaban. Compared with rivaroxaban, dabigatran was associated with a similar rate of stroke and lower rate of major bleeding. The stroke rate was almost same. That means there is no difference between the stroke rate reduction, while the major bleeding was little low with about 29% risk reduction in the dabigatran group if you compare with rivaroxaban group. So this is just to summarize what dabigatran versus rivaroxaban what is showing. So coming on to the meta-analysis of Aristophane sub-analysis, subgroup analysis, dose-wise, age-wise, gender-wise, renal disease, prior stroke, diabetes mellitus. And again for NOAC versus warfarin as well as NOAC to NOAC. So standard and low dose NOAC were studied in the following subgroups. Now there are differences in the subgroup, and the results of the subgroup analysis were generally consistent with the main results both in terms of effectiveness and safety when you have NOAC versus warfarin. It was consistent with the main group, and this is the results of the subgroup analysis on age, data, gender and baseline CHAT score were generally consistent with the main groups if you see the patients of high age group and high CHATS group. So this was consistent with what we saw, that NOAC is better in terms of safety, and similarly NOAC is better in terms of bleeding. This is all subgroup analysis. While evaluating the comparisons and major bleeding, there was significantly interacted to each NOAC versus warfarin across all age, gender and CHAT score with lower hazard ratio. Observed patients who were younger were male and had lower baseline. Coming on to the NOAC warfarin propensity match subgroup of renal disease as well as diabetes. Again, the author conclusion was that it was generally consistent with the main results. That means even if the patients who have got prior stroke or those who have patients who have renal disease or diabetes, you have similar better efficacy and less bleeding in NOAC group versus warfarin even in these groups. Coming on to the major bleeding in NOAC versus warfarin, even the bleeding in this patient was, I told you, both in terms of safety as well as efficacy. Coming on to the last part, which is mortality and sensitivity analysis of Aristophane data. If we see the mortality in the CMS Medicare population after propensity score matching, if you see apixaban, dabigatran, rivaroxaban, number of events as such, in the all NOACs were associated with lower rate of mortality compared with warfarin, and apixaban and dabigatran associated with lower mortality compared with rivaroxaban. So this is something to learn from Aristophane study, that the mortality was better or less in apixaban and dabigatran group. 1 year follow-up data. They tried to find out 1 year follow-up data, and the result of sensitivity analysis of restricting follow-up of 1 year were generally consistent with the main result. And the main result, I have told you that in NOACs were better in terms of efficacy and safety as compared to warfarin. And if you see the overall the results of this, apixaban has scored better. As I told you, I want to revise the slide which I shown you earlier. I feel that this is a very important slide when you compare the head-to-head data. Sorry, this one. Where is that slide? Okay, so I will finally conclude with that slide because that is an important slide where they have done a head-to-head comparison of safety and efficacy. Yes, this one. So this was real-world data that apixaban was better in terms of stroke, ICS, death and major bleed, and this has been confirmed by the Aristophane study. To conclude the Aristophane study, I will go back to the slide where I left you. This is the final conclusion. This is the largest known observational study of NOAC used to date. This study showed that NOACs were associated with lower rates of stroke and systemic embolism and with variable comparative rates of major and bleeding versus warfarin. And this has been in a high CHAT score more than 3.5 and high blood score. In addition, a comprehensive set of subgroup analysis provided further evidence of important differences among subgroups of patients with non-valvular AF, and it appears that apixaban fares better than other NOACs it appears, I would say, that apixaban fares better than other NOACs and warfarin in prevention of stroke and major bleeding. So this is how I conclude this slide, and I stop sharing and then I have some discussion. So to finally give you my thoughts, that warfarin is an established salt as an anticoagulant which requires in INR monitoring, which is a blood test done 1 monthly, 2 monthly or 3 monthly depending upon the patient cohort. It is still the drug of choice for valvular atrial fibrillation. That means patient with mitral stenosis or mitral regurgitation patients. Still there is no data for NOAC, there is no trial. But for the non-valvular AF, which is getting very common now, especially when elderly patients and patients who are with a rising age all over the world, not only in India, but not only in Europe and USA, but also in India, with the better facilities, now we have a more elderly population. These patients sometimes with a 6% incidence of going into atrial fibrillation. These atrial fibrillation requires 3-pronged treatment. One is, of course, control of the heart rate so that the patient can live safely because he will not have palpitation. One is control of heart rate. Second, possibility of cardiac rhythm back to them. But in chronic atrial fibrillation, it can be possible only by electrical EP study and RF ablation, which is very commonly being used in Europe and USA. In India also, we are doing RF ablation, convert atrial fibrillation to the sinus rhythm in chronic AF. And third prong is, if you are not able to convert, that means the patient of chronic AF who is living on beta blockers or calcium blockers to control the rate, he requires additional anticoagulant, which is very, very important because we have seen that many patients who actually land up with stroke, and these patients are not on anticoagulants, they are just on aspirin, and aspirin is not enough. And I have in my own family, I have witnessed many patients who have stopped anticoagulation and they have been lost because of massive intracranial ischemic stroke or thromboembolic stroke. And that's why I further emphasize the importance of doing anticoagulation. And here in this small presentation, I discussed whether warfarin is good enough or we have a better compound which will have better efficacy and more safety. And I have discussed that among the 3 NOACs which is available in India, dabigatran, rivaroxaban and apixaban has a slightly better edge in terms of safety in prevention of stroke from the Aristophanes trial as well as randomized clinical trial. But in Aristophanes, head-to-head comparison is there available, and more than 4 lakhs patients were observed. It's a huge number, and therefore we have to really believe this data that apixaban has an edge over rivaroxaban and dabigatran. But finally, it is actually this discretion and the choice of the treating physician who will choose which anticoagulant. But definitely, novel oral anticoagulants, which is out of these 3, should be used over warfarin. This is for sure. That means you have to change. If somebody is taking warfarin in the clinical practice, you find out that this is the non-valvular AF, please change it to this. And if you're starting fresh, of course, one of these 3 should be started. Apixaban has slightly better, more data will come up. But this has shown from this analysis that apixaban in terms of safety as well as efficacy in prevention of stroke and systemic embolism is better than rivaroxaban and dabigatran. Thank you very much for patient hearing. This is I conclude. Please don't miss your atrial fibrillation patients. Please give them anticoagulation. This is exclusively important. Don't stop at ecosprin. Don't stop at beta blockers. Don't stop at calcium blocker. Please give anticoagulation unless there is a major contraindication. For example, recent hemorrhage or the patient is bleeding. Then of course you can't give it for some time. But whenever the patient becomes stable, you have to give this salt. If you don't give this salt, this is actually not correct, and you have to do it. Thank you very much, and I give thanks to the people who have invited me for giving me this a little comprehensive talk on oral anticoagulants. Thank you very much.
Thank you, sir. Thanks for the wonderful presentation. The couple of queries are in the chat box, sir. By one of the doctor, what is the relevance of real world evidence as compared to RCT? And would like to know your opinion, sir.
This is a very important question. Why we don't have RCT? You see, the real world evidence are actually more important as compared to RCT from my side, because the RCT there are a lot of exclusion criteria. While in real world evidence you don't have exclusion, you have been used. People are using in various ways, and now you find out the results coming from the what has been actually being used. This is only American study. We don't have any study in India. We can also start a study in India for the observational study, which is not difficult actually. In RCT, a lot of ethical things are required and a lot of clearances are required. In observational study, it is easy, and I think we'll speak to some companies so that they can contribute and we can start some real world data from our own country, India, from various centers.
Thank you, sir. There's another query by one of your colleagues, doctor. Doctor, in patients with recent cardioembolic ischemic stroke, what is the optimal time to start or restart anticoagulation, and which NOACs you prefer in such patients?
This is a very important question, because patient is already having stroke and patient is having atrial fibrillation. You see, we always take the help of neurologist here, and when the neurologists say, because immediately we don't give anticoagulation. Otherwise, ischemic stroke can be converted to hemorrhagic stroke, and that also depends upon the size of the stroke. The treatment for the stroke, basically, if it comes within the first 4 hours or 3 hours, is basically to give thrombolytic therapy. That means you have to really thrombolize the patient, and but if the patient window period is more, then you don't thrombolize. Then of course you have to wait and watch by CT scans, and if it is a large stroke, I think they give window period of at least 48 hours to 3 days. But even before starting ecosprin, they wait, because many times a small stroke, if it is converted from ischemic to hemorrhagic stroke, doesn't make much difference. But if it is a large stroke, if the ischemic stroke gets converted to hemorrhagic stroke, then it will lead to increased intracranial pressure and patient will deteriorate. So with the help of neurologist, we have to wait for at least 3 to 5 days or maybe 7 days. And the second question is that which NOAC I will choose. I have just gone through the whole data, and you have also listened to my talk. Otherwise, all three are good enough, but definitely from the data which I have seen, and which you will be convinced by seeing the Aristophanes study, that apixaban has a edge over the other things in terms of reduction efficacy, because you're not going to change it. You're not going to change it. For example, start today, Abigatran, tomorrow apixaban. No, if you start it, you can stick to it. So this is what I personally feel from the data is saying. But of course, you are free to use whatever you want. All NOACs are good enough, but there are few. And when you see the head-to-head data, you will find a better efficacy in this. Mr. Lalwani, can I have my full picture on the screen? I'm not able to see it. I would like to see my because it is only you are always full. I am always on the side.
Sir, since we both are panelists, you will be able to see mine. But when you are talking, entire audience will see your image.
But I cannot see. But I cannot see myself. No, don't worry. No. It's just to see myself. I am visible, but on the corner.
Sir, you are exactly on the center right now. There is another query, sir, by one of your colleagues. Doctor, all three NOACs are available in India for non-valvular atrial fibrillation. In your opinion, which NOAC has better efficacy in terms of stroke reduction and safety?
This I already answered. That when you have a comparison between apixaban versus rivaroxaban versus while you have another comparative data, apixaban versus dabigatran, in both the conditions the safety and efficacy is with a larger risk reduction in apixaban group.
Yeah. Thanks. There's another query, doctor, by one of your colleagues. Doctor, in patients who had GI bleed, what will be the immediate course of action and when to reinitiate NOAC again?
Sorry, I could. When you have GI bleed, what will the course of action? You have to involve a gastroenterologist, of course. This is very important. You have to control the bleeding. You have to stop NOACs at the same time, because you see it's a chronic result. It's a chronic effect. prevention. And if you have a GI bleed, if it is large enough, of course, the hemoglobin fall, hypotension, you have to control with IV fluids, you have to give, replace the blood, it's an emergency. If it is a minor bleeding, then of course you can treat the patient at home. And of course, you have to, in both the conditions, you have to stab the NOAC and also the ecosprin if he's taking for some other reason. Then restarting will depend upon, I would request the gastroenterologist to see and do an upper GI endoscopy and to see if there is an ulcer which is bleeding. And also if it is a lower bleeding, lower GI bleed, they will do colonoscopy. And after these evaluations, if they give the green signal that of course now you can restart, it will be at least 1 month away, at least 1 month or at least 3 weeks away from the bleeding, then we can restart after a green signal. Suppose the patient who has got already ulcer, a large ulcer or which can bleed again, we have to be we have to treat the ulcer first and then wait and then restart NOAC. So this will be a difficult situation because now this patient will be unprotected, because as far as atrial fibrillation is concerned, he is unprotected for the stroke, but this is life and you have to treat according to the patient's requirement.
Thank you, sir. This last question, sir. In these days, post-COVID, sir, the patients are being given NOACs. Can we learn your experience on same, sir?
I think this is the most important question. And I like this question because I have treated more than 400 patients of COVID in my own hospital. Apollo Hospital Delhi is COVID safe as well as treating COVID. We have various areas. I would like to share my experience in another 3-4 minutes. Since the beginning in March, lockdown was 24th March. We all remember that date because this has been the terrible year for the whole world. And initially we were thinking that mask was not important. On 29th March, I remember the date because I've done more than 18 webinars. Lalwani, I've done Mr. Lalwani, I've done more than 19 webinars on COVID only with the international participation from America, from Germany, from Italy, from UK, and of course local participation from all over India, CSI, Cardiological Society of India, and we have learned a lot of things and we are still learning. So these patients, earlier it was not known because that first webinar first 3 webinars, we had the Italian doctors. And at that time, people were not even using ecosprin. Nobody thought that actually this is a D-dimer which is increased and there is a thrombotic potential inside the body, which is causing not only the lung injury, but also it can cause DVT and of course subsequent pulmonary embolism. A lot of patients were actually lost because of pulmonary embolism, not by the lung injury, especially in Italy. And also the post-mortem studies which was conducted in Italy, they found that the lungs were having hemorrhagic changes inside. Thrombosis. Multiple thrombosis was there in the lungs, and therefore they found that actually it is the main cause of concern should be the huge thrombogenic potential of this virus on the whole body. And therefore we initially were not doing D-dimer. Later on everybody was doing D-dimer, which was a marker for the increased thrombogenicity. So enoxaparin was used initially in all the patients and it is now the guideline. And as I told you that especially in the post-COVID, I will share 2-3 more personal experiences. So whenever you give enoxaparin to the patients of COVID, you have to give it, even if it is D-dimer is normal. I would say that 0.4 ml or a milligram of enoxaparin OD should be given, even if D-dimer. If the D-dimer is high, then you have to do it BD, and if it's very high, then you have to give 0.8 milligram twice a day. But you cannot give long enoxaparin. You have to change it to one of the NOACs. So NOACs are important. I would prefer that NOACs should be continued. There is no contraindication. If there is no contraindication, that should be continued at least for 2 months. Even if D-dimer is normalized, if his D-dimer was already high. If the D-dimer was not high in any case, then of course only ecosprin is enough. But of course, if the patient is hospitalized for some reason, I would prefer that enoxaparin at least for 10 days, followed by ecosprin, even if D-dimer is normal. But here the enoxaparin should be OD dose. If the D-dimer is high, then enoxaparin twice a day for at least 10 days or 15 days, whatever his hospital stay, then changing to NOACs at least for 2 months. And you have to wait and watch for D-dimer. If the D-dimer is not coming normal, you have to continue for 3 months maybe. But after coming normal D-dimer, if it was already normal, then only ecosprin. If the D dimer is high, then at least after stabilizing, it should be for at least 2 months, you should give. Ecosprin for 3 months. This is my protocol and our hospital protocol. You see, the protocols are changing every day. This is a new disease. It all depends upon your personal. I was sharing 2 examples where the patient's life was lost post-COVID because of pulmonary embolism, having DVT. They did not test the D-dimer, and there are many asymptomatic patients who are not tested for RT-PCR also. In COVID, you see a lot of patients. One of my relatives living in Maharashtra, he had actually dyspnea on exertion, and then of course some rest dyspnea. We did echocardiogram, we found RV and RA dilated. We had suspicion of pulmonary embolism, we did CT, pulmonary angio. There was a clot in the pulmonary arteries, not in the main trunk. So, what is the cause in such patients? These similar patients are being witnessed all over the world. Possibly, and D-dimer was found to be elevated, CRP was found to be elevated, RT-PCR was not done, and hemoglobin was also found to be false, positive. That this patient was actually COVID, undetected COVID, and now he has landed up because of high DDMR, now with the pulmonary embolism, thromboembolism, either embolism or thrombosis per se, we don't know, because in this particular patient, the Doppler of the lower limb was normal. But he might have DVT earlier, which has gone up. So what I'm telling you that this Novax, now this patient is on enoxaparin, and I will change it soon to the Novak, and then he will require at least for 3 months and 2 months post normalization of D-dimer. So I have given more time on this because I have a lot of webinar discussion knowledge about this particular disease, which is actually still, it has devastated the whole world. And London, you have 44, UK, you had 44,000 in one day. Fortunately, in India, the numbers have come down, but we still have to keep our fingers crossed and to see whether this can come back to us or not. And we have to be very careful. Vaccine will not be 100% efficacy, I tell you. I'm debating the talk from NOAC to vaccine. But no vaccine, you have to keep protecting yourself, and you have to keep watch on your immunoglobulins levels. If you are COVID, done earlier. If you are not COVID, then after complete mask. And of course, vaccine is good to start off. I'm not against vaccine, but they will not be 100% protective. Neither Pfizer nor AstraZeneca. Our Covaxin is having sensitivity, efficacy of only 60 to 70%. So we have to be careful.
Thank you, sir. Thanks for the wonderful presentation you made, sir. I'm sure for all the doctors, it will be really a benefit to pass on to the patients in day-to-day practice. And with this, with due regard, sir, we sum up the session, and I'm thankful to all the doctor audience for sparing their time and had a patient listening. And I am especially thankful to Dr. Professor Vivek Gupta, sir, for giving once again a wonderful presentation and help to all the doctor audience. Thanks, sir. Thanks for the great presentation, sir. Sir, I'm sure, sir, you can see your WhatsApp, sir, right now.
I will see after some time.
Yeah, I have sent the WhatsApp image, sir. I mean to say your image is much bigger and wider.
No, it was just a joke. But everybody wants to see the face. There's no doubt.
Sir, everyone. The thing is, when we both are panelists, if I will talk, then audience can see my face on the center, and if you are talking, the audience will see only your image. My image will be on the one corner, very small image.
No. You are looking smart. Don't worry. you need a wig, but I don't wear the wig.
Thank you. Thanks.
It was a pleasure talking to you, and it was actually a real pleasure to have this study and discussion. And I thank to your medical colleague Jaspreet. She spent a lot of time, especially after midnight, and when I was free. So I really thanks her because we had a lot of discussion on the slides and other things. And I hope the talk was very informative to everybody. And a lot of people, I have got many people, public also watching who are non-medical, and they will understand that the palpitations, to summarize for them again, to palpitation means दिल की धड़कन अगर हो रही है तो atrial fibrillation rule out करना चाहिए. अगर atrial fibrillation की बीमारी है, it is not life threatening. Normally it is not life threatening. One should not fear that much unless you have a stroke. और stroke को बचाने के लिए एक ऐसी खून पतला करने की दवा दी जाती है जिसमें अलग 4 तरह की दवाइयां अवेलेबल है। तो आज हमने डिस्कस किया कि कौन से 4 में कौन सी बेस्ट है, किसमें रिस्क ऑफ ब्लीडिंग कम है और किसमें प्रिवेंशन ऑफ स्ट्रोक यानी कि पैरालिसिस होने की संभावना कम है। तो ये डिस्कशन था आज के इस टॉक का, एंड आई एम वेरी थैंकफुल टू मिस्टर लालवानी फॉर गिविंग मी दिस अपॉर्चुनिटी to discuss this particular talk. Very important actually. Lot of patients are lost in stroke because of either they are not detected or they are not properly treated. Thank you very much.
Thanks, sir. Need your support, sir, for Eliquis 2.5 and 5 milligrams, sir. Thank you, sir.
Thank you.
So we can disconnect this session. Yeah. Thank you, sir. Thank you.
मैं इसको फिर से एक बार आपको बताना चाह रहा था कि एट्रियल फिब्रिलेशन एक ऐसी बीमारी होती है, जस्ट एट्रियल फिब्रिलेशन एक ऐसी बीमारी होती है जिसमें कि हार्ट के अंदर की रिदम गड़बड़ हो जाती है। जब हार्ट की रिदम गड़बड़ होती है तो हार्ट ऊपर का हिस्सा बहुत तेजी से दौड़ता है और नीचे का हिस्सा भी तेज चलने लगता है। तो हार्ट काफी तेज चलता है, लेकिन क्योंकि इसके उपज ऊपर से हो रही है इसलिए लाइफ रिस्क नहीं होती। अगर यही वेंट्रिकुलर फिब्रिलेशन होता है तो पेशेंट की सडन डेथ हो जाती है, इसमें नहीं होती। तो ये अच्छी बात है, लेकिन इस बीमारी में स्ट्रोक यानी कि पैरालिसिस होने की संभावना काफी ज्यादा होती है। तो इस बीमारी में खून पतला करने की बहुत ज्यादा जरूरत है। कई बार डॉक्टर्स आउट ऑफ इग्नोरेंस या आउट ऑफ पेशेंट दिखाने जाता नहीं है तो मिस हो जाता है। तो मैं सारे डॉक्टर्स से जितने और बाकी पेशेंट्स को भी कहेंगे कि अगर इस तरह की बीमारी आपके किसी रिश्तेदारों को है तो उनको इस तरह की दवाई, खून पतला करने की दवाई बहुत जरूरी शुरू करना है, नहीं तो कभी भी स्ट्रोक हो जाता है तो बहुत ही, बिकॉज स्ट्रोक इज ए लाइफ डिसेबलिंग कंडीशन लाइफ लॉन्ग अनलेस यू आर ट्रीटेड इमीडिएटली। सो इस तरह का ही था। डॉक्टर विवेक गुप्ता फ्रॉम अपोलो हॉस्पिटल ऑन 29th of December at about 5 p.m. Thank you.